The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. Welcome to the OHA COVID-19 OREMSIS Charting Update webinar. And let's just do a quick sound check for everybody to make sure that everybody can hear us. Anybody in attendance? Type into the question box. Just make sure that you guys can hear me. Perfect. Okay. Here we got some people. Awesome. Thanks, you guys. So welcome again today. My name is Rebecca Long. I'm one of your facilitators, the Mobile Training Unit Coordinator for the Oregon Health Authority. And one of my co-facilitators is John Crabtree, one of our data coordinators. Host for today, we have Peter Geisert. He is the interim EMS and trauma data manager. We also have Andy Nunez, EMS and trauma system research analyst. And we also have Dr. David Learfield, the state EMS medical director. Thank you guys all for joining us today. And I'm going to change presenters and welcome Peter and Andy. Switched over here for Peter's screen. Welcome, you guys. Thanks for joining us.
Thanks for having us. This is Andy. I'm going to wait for Peter to get his screen live here, but I just wanted to take a minute to acknowledge everyone for being with us today. I know everybody's very busy. We've got a lot of field personnel and admin support folks, and I just wanted to say thanks for being with us today.
Okay, hang on, Andy, 1 second.
We're gonna.
Peter, if you want to go up to the display settings and click display settings on upper left in the middle, because you're on kind of where you can see the next slide. So up in the upper left, it'll say display settings. Yeah, click on that and then swap presenter view. There you go. Now it's full screen. Is that okay for you, Andy?
That's perfect. And we can go ahead and go to the welcome slide again. And we are just going to, great, thank you. All right. Yeah, so today we're here to review some changes to Oregon's electronic patient care reporting forms. We'll share some details regarding changes to some specific OREMSIS fields and give you a sense of what to expect when you're filling out data in these new fields. And then Peter will walk through the basics for updating your forms, and then we'll discuss some motivations for some of these changes, hopefully leave some time for Q&A and maybe take a peek at some of the data that we're seeing so far to date. So let's go ahead and jump right into some new data elements. Next slide. All right, so these fields are new fields that Oregon has not collected in the past, and they have been enabled in the state elite system. We have 5 new fields relating to recent travel. eHistory 901 is a yes or no field of recent travel. 902 is a text box that can enter locations, and then 904, 5, and 6 are going to be drop-down lists for choosing specific international, state, and city destinations where a patient may have traveled. We're enabling a new vital signs field for recording temperature. And when we get into some of the details a little later, you'll see why this is especially important for even patients not presenting fever in the field. And then we have 4 other fields relating to tracking PPE use for all responding individuals. The crew member ID field is E-Other.04, allows us to track PPE specific to an individual, as well as the suspected and type of exposures. Those are also specific to the individual crew members. And so all of those data fields are new for us. And next slide. We have a few more fields these are more familiar, but we've added some elements to help us deal with the current situation. Going back to eHistory, we've added 2 options for medical and surgical history. B97.0 29 is the code for a patient who has tested positive for COVID. Maybe this is a patient being transported, but either way, this other coronaviruses as cause of disease classified elsewhere is reserved for patients that are confirmed cases. Z20.9 is when we can't confirm a positive COVID test diagnosis in the field. So it's a little more generic, but still allows us to see that in the medical history. And then we also have a couple new procedures enabled for the field for e-procedures 0.03. We have EMT taking the nasal swab, and then also a field for applying a mask to a patient. Next slide, please. Then additional, well, these are more fields that we've collected before, but we have new elements added to them. For e-disposition, when we do a pre-arrival alert or activation, we can say yes, that there's a biological infectious precautions for when we're bringing a patient to a destination. We can alert them ahead of time with this field. And then additional other custom values, and this is again going back to the being able to track PPE for specific individuals. There are reuse options for several of these different PPE types. And we've also added the N100 masks. There are some folks in the field using this for intubation procedures, and so we've got those in both the new and the reuse as well. And next slide. And then finally, we're asking for some special attention in a few of these data fields for crews transporting these patients. In primary symptoms, we have in the Word document guidance, there is some details where we can add for shortness of breath and fever and cough. And then additionally, for primary and secondary impressions, adding the, excuse me, sorry, cognitive and respiratory and fever impressions as well. And then also taking time for in the patient care report narrative, adding COVID-19 suspected where that is appropriate. Peter, do you have anything else to add to this to that slide, or?
Yeah, I think just in terms of primary symptoms or other associated symptoms, just documenting what you're seeing with the patient versus the impressions, and looking to document things that can be, verified in the field, and trying to capture sort of that decision-making process in the narrative if it's related to the possibility of COVID-19 infection.
Great, thank you.
So,
and then now it's we're handing it off to Peter at this point too. So thank you.
All righty. So these changes have been implemented within the state of Oregon's Image Trend Elite system. And we have also updated the state standard forms to reflect these changes. So all of these elements are available in those forms if you use the standard forms. However, if you use custom forms in Image Trend, you will need to incorporate these new recommended elements. Similarly, if you work with a third-party vendor, you'll need to work with them to implement the changes. So these are all national custom elements. So chances are your vendor is already has these available, or they are in development. So this may not be as daunting a task as it might first appear. But we have had some requests for assistance with updating forms. And so for many people, this may be a review, and I beg your pardon, but I'm going to run through just very quickly where we incorporated some of these new fields into the Oregon standard EMS forms, and just a brief overview. So when you want to update your forms, you can go into the pull-down menus in the upper left-hand corner and select in the Tools menu, Form Manager, and that will take you to a screen that looks something like this, and you'll select your agency's EMS form. And that'll give you a window. So as you move across the screen from the left-hand side towards the right, you're going from more general to more specific, and you select a section, then a panel, and then the individual data elements will appear in that central panel. Notice this data set window can find data elements that you might want to add to your form. And so from that window, you can use the search bar to search for a data element, and then you can literally just drag it into the form, and it's that simple. So to add the temperature data element, you would search under eVitals 20 window, and that would pop up, and you can navigate to the section and the panel that you would like to locate that in on your form, right? So here in the Oregon form, we have this under Activities, and then Vital Signs and Vitals, and you can see we just dragged temperature into the top of the form there, or actually it's the middle. That's a scrolling window. So similarly, with respect to EMS personnel and PPE documentation, we drilled down through the scene section and panel to EMS personnel exposures, and we dragged those, put those data elements into the form there. And here's where we placed patient history, recent travel, and destination under patient history. And we took all 5 of those travel-related elements and added them to the form right there. So if you're amending your forms and you need some assistance, don't hesitate to reach out. I'm happy to work with folks. And we do also have a guidance document that went out with the email blast this past week. So you can look for that or reach out to us, and we're happy to assist. So now I'll hand it over to Dr. Lehrfeld.
Thank you, Peter and Andy.
Is he there?
Everyone hear me? Yep. Yeah. I had to unmute myself. I've got too many mute buttons going on. Rebecca, could you share your screen with me? Or share my screen?
Yeah, sure. Sorry about that. Here we go. Did you get a...
I did, and I clicked it, and I'm
Perfect. There we go. Now we're on the NEPSIS.
waiting for it to happen. Okay, so you can see that screen.
Yeah, version 3 state dashboards.
All right. So, you know, the question, our primary job is to take care of people, and you know, recording this information is just a bonus as long as we do what's right for our patient. But the reason we're interested in all data, and this data specifically, is because we use it to inform our decisions. In the EMS medical directors and public health at large, what I wanted to show you was how we look at some of this information you're putting in the charts. What you see, hopefully you see, I can't see what you see, but you should see a website called NEMSIS version 3 state dashboards. And there's a number of dashboards here. The one I wanted to show you was the influenza-like illness dashboard. Now this existed before the COVID pandemic came out, but it's been modified since then to track COVID as well as flu-like diseases. And some of the ways it's been modified is that the data points that Andy and Peter were talking about have been added to it. Well, these ICD-10 codes were used in the inclusion criteria, a lot of them about influenza. The coronavirus and SARS has been added as well. And some of the symptomatology has been, and contact tracing has been added here as well, you can see. So those diseases are going to be lumped into here. And the reason it's lumped together is, for the most part, it's impossible to extinct at any single point in time to distinguish exactly what respiratory pathogen you're dealing with. But from other data, we know from testing data in OREMSIS, which is our infectious disease lab reporting system, we know how many flu swabs are coming back positive versus how many COVID swabs are coming back positive. And we can correlate that to this data. For instance, now we know that there's almost no flu A coming back positive now, but we've got lots of COVID coming back positive. So we can correlate that with spikes in the ILI surveillance dashboard to get a pretty good idea about which respiratory pathogen this represents. The way these visualizations work is they give you some big patient characteristics. You can zoom in by state or national, and these are not publicly facing dashboards. These are only for public health professionals. And if you click on any one of them, you can see that you can get exact information, what the total amount of charts are, what the percentage is. You can break down the rest of the charts by just clicking on that one, and it'll only display information from that category, and you can choose several categories that you want to display information from. Hopefully this doesn't crash. This has been being used so often that it's actually brought down the website several times in the past week. So I'm going to apologize for the slowness here.
And David, while you're waiting for that to load, I just want to let everybody know that's on the webinar too. The handout that Peter was referencing that was emailed out last week, it is in the handout section of your control panel. It looks like a little piece of notebook paper on the right side. You can click there and download that OREMSIS guide for these new changes.
So as we go down the dashboard, we can use this information to correlate some of our predictions. So the Institute for Infectious Disease Modeling predicted that our peak would be just at the end of May and April, and we can see here that it actually was. We can see this dashboard here is a percentage of EMS calls that were met the inclusion criteria for ILI, and the blue is the actual percentage per day, and then this is the red is a 14-day floating average, and we can see that it peaked exactly when our model, the week that our model said it would, and then it's been dropping down ever since then. So again, we can correlate this with existing data that we get from OREMSIS, that we get from our modeling, that we get from Essence, which is our ED surveillance system. And when we see consistent trends within all our surveillance data, we have more confidence that what we're looking at is real. We also generate heat maps with this, and we can see which counties, and again, we've set this up not total, but by percentage, are being hardest hit with ILI calls. So you can see in Lake County, it's up to 6.6%, not because the total amount is, the total number is large, but it's just a high percentage of their calls. Where cases from, if you read the media, you'll know that Washington County was particularly hard hit. The total percentage is lower, but the total number of cases is large. And again, using the tools up here, we can just pick a particular age group, a particular demographic, or a particular area, and the dashboard will display information just from there. So when they want to know about resource allocation for PPE, or where an ambulance strike team needs to go, or where the disease is picking up next, we can correlate this with other health system data to to determine total numbers and percentage of where the need is in our state. You can see here the top 15 complaints, which is what we also see with some data we're going to talk about later. This is going to inform our policy making. So when we put out instructions to the PSAP to screen certain calls, it's not just because we're guessing. We have this data here to show that the largest dispatch complaint for patients with influenza-like illness is breathing problem, and second is sick person. We've seen these trends in our EMS data as well when we correlate these with actual known tested positive cases. And then it goes on down, non-traumatic chest pain, falls. A big one is interfacility transports as well, we're seeing on these. And then we can see where they're coming from and where they're going. So despite reading about nursing home outbreaks in nursing homes, we can see that ILI illness private residences is actually the largest one, with group homes being second. But I don't believe that nursing homes even made the top 10 list in here. And then by far and away, we go to emergency departments. We really haven't set up any alternate care sites for ILI, and so that's going to still be our biggest avenue for taking care of these patients. We can also look at the patient dispositions. Scary number of patients actually are patient refused, patient released, and we can drill down into those charts to see exactly what's happening there. And then provider's primary impression and the primary symptom. Acute respiratory distress. This is basically altered mental status or lack of energy, weakness are the big two ones. And then so all this data helps us drive our policy making. It helps us drive our decision making. Other things you can see in these dashboards are when it comes to protocol changes, scope of practice on different dashboards. Like this one, that will show us by state exactly what medications and procedures are being done. This is helpful when the Oregon Medical Board needs to make scope of practice changes. We can say how much of each of these medications is being given, and you can sort it by provider level as well. This informs our decision making for protocol development and scope of practice changes as well. This is just a brief explanation of what we went over, the elements included in the ILI dashboard, age and sex, month and year, time of day of activations, and then you saw the heat maps, complaints by dispatch and disposition, primary impression, symptoms, and location and destination type. Let me share with you, so that's the ILI dashboard, and that's how we look at the data. And some of the things we're doing with this, I don't believe, Peter, you didn't cover this, did you?
Which do you want?
These last few slides. No, I'll throw this.
We still have the 3 slides left to go. Yeah.
Okay.
Yeah.
Let me see. Why is it not?
And I also have some visualizations and primary impressions and so forth available to look at.
Okay. So
for our COVID positive.
See if I can get this working up. Okay, there we go. One moment here. I'm having a hard time getting this to display right. There we go. So I think, Peter, you're going to cover this. I just wanted to show, really quickly. So what you saw on the dashboard was suspected influenza-like illnesses. What you're seeing here, and you may have seen it before because we put it out in one of our weekly newsletters, is actually laboratory confirmed cases of COVID-19 that we know because Peter was able to link the OREMSIS data with the EMS data. We know these cases were transported by EMS and they actually tested positive for the disease after the transport. And then we looked at their dispatch chief complaint, and this would inform our directives to the PSAPs and to EMS. You can see that when we first started looking at this, it was, as in the dashboard data indicates, it was exclusively sick people and breathing problems. And so when we put out our official guidance, we directed the PSAPs to screen just for those two chief complaints, and then ask the questions about fever, cough, and shortness of breath, because again, we knew from the dashboard that these were the primary symptoms that people were complaining of. As the number of cases picked up, we started to see a significant divergence. Even though sick person and breathing problem were the majority of cases, there was a significant amount of other complaints. And because of that, we actually changed our guidance to the PSAPs that they should be screening all calls. So this is just one way that data is used to inform our policy making and to inform our protocols. And Peter, you want to take back over?
Sure. Let's see.
Peter, let me give you controls. One moment.
Okay.
There you go. You should see the perfect.
Okay, let's see. I'm not seeing.
So you just need to go. We can see your screen right now. So if you just go back down to your PowerPoint presentation.
Okay.
If that's what you want to reference.
Well, so I think that a lot of this Dr. Larafeld covered. We have these 3 slides here about.
Hang on, Peter, we can't see. There you go. Sorry, we were on the other screen.
Okay.
And then if you want to go back up to display
display
settings. Yeah. Perfect. Thanks, guys.
Yep. So track, one of the things we want to be able to do with this is to track PPE and PPE usage. And then here's the ILI dashboard that you saw, and then linkage with OREMSIS to be able to do a number of things to look at. And let's see if I can manage to show this to you. I would like to share some of this data. Let's see. I can't see what you can see of my screen.
Currently, we're looking at your Google industry standard EMS population estimate screen.
Okay.
There you go. Perfect. That's full screen now on that graph. That looks great.
Okay. All right. So up here at the top, so these are confirmed cases of COVID-19. And then we pulled data from the EMS system and matched on a sounds like match between the name as well as using the age. And this winds up being a pretty strong match. So these are confirmed cases, and I broke these out by age. So you can see there's a pronounced difference between the younger age group, and as we get into higher age groups, ultimately it's older people who are transported more frequently. And we also see a similar peak and drop off in these data. So this runs through the middle of this month if I'm not mistaken, I think the 15th. So to highlight some of the issues we were discussing before about documentation of PPE. So pulling out all of the records for these individuals and then looking at the individual EMS personnel on the call and whether the field for PPE usage was completed. This was only the case in 23% of those records. And remember, this isn't 23% of all records. This is of COVID cases. So part of that may just be that folks have not filled out that field with the PPE that they are using. But it's very difficult to be able to estimate PPE usage without increasing the completeness on that field. So here below we have some primary impressions. One thing that of course leaps out at me is that injury other unspecified is a major category for primary impression here. And then you have many of the impressions you would expect, respiratory symptoms, shortness of breath, influenza, weakness, cognitive and altered mental status, coronavirus. There's our new value there. But then we get down into some other, pain-related, as well as even as behavioral complaints and chest pain. As we go down further, I've got symptoms. So you can see there are many records for which the primary symptom was missing in these data. But we're also seeing shortness of breath, and then general symptoms and signs, but weakness, cognitive. So many of these are very familiar and the things that we would expect to see, but there is a bit more range to the types of values and the types of symptoms that people might be displaying. And dispatch complaints. Here we see our transfers and interfacility transfers, sick person complaints, breathing problems, fainting and falls is a major one. So these are the types of things, the types of calls that you might be responding to who may potentially be COVID cases. Any questions on that, or if anyone has anything else to share related to these frequency tables?
I think, Peter, that's great. That's what we've seen pretty much consistently along with the data. We have quite a few falls, altered mental statuses, maybe even psychiatric behavioral as a form of altered mental status. It does emphasize that although this is primarily a respiratory pathogen, it does trail off into quite a few types of presentations, to include GI, to include altered mental status. And, because of that, there is actually some real trauma going on out there, especially in the nursing homes and care facilities as people as frail people succumb to the disease and then have falls and broken hips, etc.
Awesome. Well, thanks, you guys. If you guys have any other things to add, just jump in. But I can start with. We have about 5 or 6 questions we could go through right now. Does that work?
I'm ready.
Let's hear some questions.
Perfect. Okay. Well, first question I think is pretty easy. Are you guys okay if we share this PowerPoint presentation to people who request it?
Certainly.
Yeah.
Okay. Thanks. Next question. This was again from early in the presentation. So I think when Andy or Peter were talking, and the question was, what about the recently added COVID-19 criteria? And I'm guessing maybe that person can specify, was this the new COVID-19 symptoms, signs and symptoms maybe? I'm not sure who wants to try and answer that.
I'm unclear on the question.
Okay, well, we'll see if we can have them follow up. I think they're maybe asking about, when you're asking about the new fields and adding, it might have been, yes, the new symptom criteria. So the new symptoms that the CD has added to things to look for, are those going to be added to the data sets?
Oh,
Peter,
I think
they already
that
are in
all
ours,
of the,
right?
yeah, I believe that those are what Andy was referring to are common symptoms that are observed, and so those are all values that are available for those fields currently in the system.
Okay, perfect. Thanks. Next question. Is temperature not already one of the fields required in vital signs? Because I think we already have
Temperature
that.
was not required. It was not a required field, and Oregon was not previously requiring collecting that field. It's a new one that we added.
Okay.
So just to clarify, it was available, right? It's always been an available vital sign, but you can create a chart without recording a temperature because, you know, in many cases, people we take care of, the temperature isn't one of the most relevant values.
Okay. What if EMS does not know or have the information related to the patient having confirmed case of COVID? Can they leave a blank, or is there an unknown option?
This
think in that case,
goes back to the. Sorry, Peter, go ahead.
Oh, I was just going to say, if you don't have that information, go based on the symptoms and the things that you're able to verify in the field. That's not always obviously most people that you come into contact with will not have had a previous COVID test.
Yes, that'll mainly be for interfacility transfers, but so these are ICD-10 codes that were added, right? So you'll always put, you'll always fill in what the patient's symptoms are, and that's a multiple value field, so you can enter multiple symptoms, right? And you can also do multiple impressions as well. So you just record what you know.
Okay. Thanks for that clarification. One of you, I think it was Peter earlier, referenced recent history. How far back is recent history? 2 weeks, 30 days? Are you asking us to record the travel history for all patients or just those with COVID-like symptoms?
I believe we're asking for 30 days at this point. Yeah.
Okay.
And again, only if it's relevant. So, you know, right now we're talking about respiratory pathogens, but a couple of years ago we were talking about Ebola. So if you want to record travel history on every single run, if you have the bandwidth to do that, by all means go ahead. But as with anything in medical charting, we want to we want to document the pertinent positives and the pertinent negatives, right? And it's up to the provider or your protocols to designate, you know, what is a pertinent positive and negative.
Okay, thanks. Is the field form updated as well? Does that make sense to anyone?
I don't know what that is.
Actually, so this is actually a question that I don't know the answer to, and I feel like I should talk with Josh Legler after this. We've edited the standard state forms, and I don't know if the field forms populate from that. I'm not sure. Let me look into that, and perhaps we can send out an answer to this after.
Sure, we will have the email list of everyone who attended today, so we can send out a little follow-up for sure. And maybe Dr. Lehrfeld, when people test positive for COVID, do we know of a percentage of people that have sepsis, or is it just a positive test? It's not the, might be.
We do have, I don't know that we have diagnostic codes on them. And I don't have it in front. We do know of the positive tests, how many were hospitalized, how many were sent to the ICU, and how many were put on ventilators, and how many died. But I don't know that we are tracking hospital discharge data or diagnostic data. I have not seen that.
Okay. Another question. Some of the data. Go ahead, Peter.
I was just going to say I just received a text that says that fields should automatically update on sync when they log in.
Okay.
Thanks, Mike.
Yeah, I just saw a comment from Mike. I'm like, this person knows what they're talking about. I was gonna post that in a minute, but thanks, Mike. Next question. Some of the data set fields are grayed out and cannot be adjusted or added, like e-history 902, recent city travel. Do you have any suggestions for that?
Where are they grayed out specifically?
I'll have to have that person follow back up, but it sounds like in their charting system it's grayed out. So that maybe, is that an internal system thing that they need to change?
I'm not sure. Okay. I would say if you're having difficulty with that, reach out to us and we can troubleshoot. I would like to see specifically what you're referring to, so maybe we can do a call and screen share.
Perfect. Okay, thanks, Peter. And for the several people that have asked for a copy of the presentation, I already created it as a PDF and it's in the handout section. So please look to the handout section of your control and you can download that, the presentation. This is all being recorded as well and we'll post it on the COVID website.
And Rebecca, this is David. If you want to also throw in a link to the OHA COVID website, where there's a situation in Oregon and it'll give you a data dashboard, daily updates and weekly report. And there you can look at all the positive, negative tests, what was the disposition of the patients, hospitalized, not, ICU, not, age, race, ethnicity, sex, all that is in there and it gets updated daily and weekly. And then there's a couple of Tableau trend charts in there showing all the positive and negative cases.
Thank you. I just added the list, the link for our, the main COVID webpage, and I'll look for the other data set one here in a moment.
It's on the main page. They'll just scroll down and they'll find it.
Oh, perfect. Yeah. Okay, so it's in the chat section for everybody. You should get a little comment bubble that pops up. Another question, can you add goggles to the PPE list?
Yes, I believe we can. Let me look into that. I'll make a note.
Okay. Those are the questions
if we
have
do
so far.
Adding goggles on there, we should probably add its reuse as well, because goggles are going to be a reuse item primarily.
It is an existing
understanding that? Right, and we added reuse values for other existing things like face shield and such. So if we should just follow up and make sure that there's a reuse option for goggles as well.
Yeah.
Those are the questions we have for right now. We'll give everybody a couple more minutes to think about if they have anything else they want to ask. I appreciate you guys' time today. Thank you all for Andy, Peter, and Dr. Learfield and John for helping put this on today. This has been great information. Anything else you guys want to add in the last minute or so while we're giving people time to think of questions?
No, I just want to thank everybody who's listening again for everything you're doing out there. We know most of our healthcare system is shut down and you guys are at the tip of the spear. And it just needs to be said that we know that a lot of the healthcare system is riding on the back of EMS right now. And so we're appreciating every little thing you're doing. And we know you're out there putting yourselves at risk with this infectious disease. So just be safe and keep doing the great things you're doing.
Well said, Dr. L. One last question. I think I know the answer to this, but just for clarification for everybody, the changes to the EPCR, are they going to be a requirement for the small non-transporting agencies? And I'm pretty sure the answer to that is no. But David, could you clarify that just a little bit on who's required to submit a chart?
Yeah, so only transporting agencies are required to participate in OREMSIS, but we will provide free software, and we even have grants for hardware from time to time for non-transporting agencies that wish to participate.
Okay, so not required, but if they'd like to, they can definitely help get some access to it, to doing that.
Yep. Yep.
Awesome. Well, those are the questions we have for today. So again, I want to thank everybody. Thank you, Peter, Andy, John, David, for participating. And
Thanks,
thank you,
everybody.
Thank you.
Yeah, thanks everybody
Thanks,
for
guys.
tuning in. Again, it'll be
Thanks,
recorded.
everyone.
And have a great afternoon, everybody.
Take care.
Bye-bye.